I'm going to talk about the optimization of the microcirculation and the use of vasoactivations. For this talk, I have no conflict of interest. I think it's first important to realize that under normal circumstances, your microcirculation is controlled by local factors, not by your cardiac output and not by your mean arterial pressure. We manipulate the microcirculation with local factors. This is a study Eva Klein did, and what she asked patients in neurosurgery who were awake is to do this. And I hope you all agree that this doesn't increase your cardiac output. But what you see, if you target the microcirculation of the brain with a flow device, and you identify the region where this is controlled, and that's what we did, of course, before surgery, and you place these flow probes on that part of the brain, that as soon as you are doing this, you see an increase in flow in the brain. This has nothing to do with an increase in blood pressure, nothing to do with an increase in cardiac output. These are local factors. So that's how we regulate microcirculatory blood flow under normal circumstances. And now if you go to, let's say, somewhat manipulated normality, this is a pig where we did a gastric tube reconstruction, and we did the study because we had a lot of discussion with the surgeons who thought that the vascularization or the perfusion of the gastric tube was related to blood pressure. And I said, well, I don't agree. The blood pressure is not important in this model or in this surgery. I think it's much more venous congestion. So finally we did the study, and Eva did the same study, and she looked at the different levels of blood pressure. We went to as low as 50 millimeters of mercury up until 130 millimeters of mercury. And Eva divided the different regions in the gastric tube into different blood pressures, and as you can appreciate, it's more the region that is important, and that's the more distant you are in the perfusion of the gastric tube, the worse the perfusion, but it's not the blood pressure. And if you look at from 50 to 120 mean arterial pressure, there is no effect on the microcirculation. So and this is of course not a very sick animal, it's let's say operated on, so there is some systemic effect, but this is of course not sepsis, but this is more or less in the normal circulation. It's local factors or vascular factors that we create because of the surgery. Now there's a lot of discussion whether blood pressure has a very important effect or no effect at all. And of course, in normal situations, there is autoregulation in some of the areas, especially for the brain. That's very important. And some other organs, like the kidney, are influenced by perfusion pressure, by mean arterial pressure as well. And they always come up with the same graph. It's always this graph where there is autoregulation, and so you have, let's say, normal blood flow over a wide range of mean arterial pressures. And then some diseases shift it up, or some diseases create a linear relationship between pressure and flow. So the higher the pressure, the higher the flow. But this is, of course, not true. In principle, in theory, it's true. But in clinical practice, we have a lot of these relationships. It's not only one, and it's not a fixed one. It's not like you come into the ICU and the relationship between pressure and flow is this one, and that's it, until you leave the ICU. That's not true. It can be this in the morning, it can be that in the afternoon, it can be this after fluids, it can be this after inoxymol. We don't know. We have no studies. And so I think this is an important concept to take into account. Because we see it in some neurosurgery, traumatic brain injury. If you increase the blood pressure, you see a huge increase in ICP. There's a linear relationship between pressure and flow, and in some it's not. So the concept of autoregulation is important, but we fuck around with this autoregulation a lot with all the drugs that we use. The fluids, the norepinephrine, the inoxymol, the catandrin, the nitroglycerin, whatever you use, dobutamine. And so I think the real question is not this high and low blood pressure, but do we indeed have a problem in the oxygenation of tissues when we have a low mean arterial pressure, when we keep venous pressure low and so don't cause venous congestion? And I think the answer is still not definitive. Now, we talk about vasoactive agents and what's new. Well, let's look at what was old, because Christian Boerma a few years ago did a nice review in intensive care medicine where he listed all the drugs that the majority of drugs that we use in the ICU and what were data on the effect of the microcirculation. And when you look at the adrenergic vasopressors, he found norepinephrine and phenylephrine. And basically what they found is that there was not a lot of effect. It's not like if you use norepinephrine, you will shut down your microcirculation. That's what the surgeon will tell you, and that's what the cardiac surgeon will tell you, and that's what the neurosurgeon will tell you, that a lot of vasopressors will shut down your microcirculation, but at least in critically ill patients that are fluid resuscitated, these are of course not hypovolemic patients, that's a clearly different population, but these are resuscitated patients where you need, or you think you need, vasoactive agents to increase the blood pressure. There is not a lot of effect in the sense of a negative effect on your microcirculation in the studies, and that's 4 studies, so it's not a lot. If you look at another agent frequently used to increase blood pressure, the vasopressin and its analogs, he found at that time 3 studies, 2 case reports of 1 patient and 1 study in 8 patients. And the effect was variable. There was no difference in a vasodilatory shock and in a septic shock where they used terlipressin. There was a huge shutdown of the microcirculation and the patient died very rapidly after the shutdown. But in the vasodilatory shock in the Brussels, this is Brussels and this is Leeuwarden, they didn't see any effect with vasopressin. And in vasodilatory shock post-cardiac surgery, that can be a very significant problem. There was some decrease in the stoma, in the jejunum, and an increase in CO2, but that's only in 8 patients. So not a lot of data on this in the microcirculation. Then inotropic agents, somewhat more studies, especially on dobutamine, one on dopexamine and one on levosimendan. And basically, there was an improvement in the microcirculation in most of the studies. An increase in gastric glucosal blood flow, a decrease in PCO2, so the old tonometry thing, and an increase in sublingual microcirculation with the SDF, the OPS imaging device. So a positive effect of inotropic agents. And then finally, and this is a Dutch thing, as all the studies in 2010 in the review were Dutch studies, nitroglycerin and catenzarin, and in most of the cases there was an improvement in the microcirculation, increase in sublingual microcirculation, or no real change, or an instantaneous increase, or no difference. So basically in half of the studies there was a positive effect, but no negative effects, although some of these decrease your blood pressure. So that's 2010. An important aspect, and John Inch already showed it, an important aspect in all of these studies is when do you use these agents? When the microcirculation is bad, or when the microcirculation is not bad, but the blood pressure is not okay, or the cardiac output is not okay. So what is the reason to start your therapy? And what do you expect from it? And I think it's important that this is a very important slide. What the group of Arnaldo Dubin showed is if your microcirculation is normal and you increase your blood pressure, then your microcirculation has only one way to go, and that's bad. But if your microcirculation is abnormal and you increase the blood pressure, there's something to gain. So the first message is if you have abnormal microcirculation, then do something about it. But if your microcirculation is normal, what's the problem? Now we could extend this to blood pressure, and Some of you who know me know that I am a favorite of keeping the blood pressure low when the microcirculation is normal. Actually, Yuka Takala is doing a study now. We did a very small study using this concept. If your microcirculation is normal, don't care about the blood pressure. But this is an important message. And he also showed that it's not related to cardiac output. And that's what Kostjan Denal in Erasmus also showed in Rotterdam, is in patients with severe heart failure, nitroglycerin had a great dose-dependent effect on recruiting the microcirculation, but this was not related to cardiac output. The microcirculation improved both in patients that increased their cardiac output, in blue, but it also improved in patients where there was no improvement in cardiac output. So the recruitment of the microcirculation doesn't seem to be a blood pressure effect, unless you have a severe problem in some specific cases, as Arnaldo Dubin showed. And it doesn't seem to be exclusively related to increasing cardiac output. New and not shown in the review of Christian Burma was the study of Morelli looking at levosimendan, where he showed that levosimendan might even be somewhat more effective than dobutamine in septic shock patients. And other later studies, effect of vasopressor receptor antagonist, looked at the effect of terlipressin and AVP, and the conclusion was that there was not a huge effect. Of course, if you add another vasopressor, you can decrease the original vasopressor. That's no news. Unless you are afraid about the adrenergic agents, then it's something else. But if you add vasopressin to norepinephrine, then of course you can decrease your norepinephrine. But replacing one with the other in this study of Morelli did not change the microcirculation. But remember that in most of the patients, the microcirculation was already normal. So if you already have a normal microcirculation and you replace one vasopressor with the other, that's not a huge effect. Alexander Lima from Sao Paulo, who is a postdoc now in Erasmus, finally did a study on can we change the microcirculation? Can we change the abnormal microcirculation into a normal microcirculation? Because that's basically the question we have. If you measure the microcirculation with whatever device, but there is no treatment, then why bother? Then don't measure it. You only add noise to your clinical assessment. And nitroglycerin is used very frequently in the Netherlands when patients are cold or blue or abnormally perfused and stuff like that. We frequently bolus nitroglycerin, but there were no studies, except for the Lancet study of Peter Sprunk, where he showed that the microcirculation improves when you give this bolus. And so Alessandro did the study, and he did the study in patients with abnormal microcirculation, and then he increased an infusion of nitroglycerin from 2 to 4 to 8 to 16 milligrams per hour. That's a lot of nitroglycerin, 16 milligrams. And what he did is the time of the maximum dose, and so the dose was increased until the microcirculation was normal, and that was the maximum dose. 4 patients needed a lot of nitroglycerin, but the rest was fine with lower doses. And at maximum dose, the blood pressure had decreased from 75 to 61, something that we are not, let's say, concerned about in Erasmus, but in other centers and countries, this can be a huge problem. It has taken me 2 years to convince people in New York, where I also work, that this is not a real problem. And now I see that once they have used it, they start bolusing, well, not bolusing, they're still afraid of boluses, so they start infusion pumps and see the improvement in the microcirculation. So it's a real problem. In some patients, you can have a significant decrease in blood pressure, but despite the decrease in blood pressure, all parameters that we use to assess the microcirculation, capillary refill time, perfusion abnormalities, they were all corrected. If you stop the pump, they became all abnormal again. So yes, we have measures to improve the microcirculation. Now, you could say, okay, that's great. We improved the microcirculation, so let's give nitroglycerin to everyone. Just like the study from Jean-Louis Vincent a long time ago, adding 5 micrograms of dobutamine to every patient, showing that there was an improvement in DO2 and VO2. Christian Boerma did that. Give everyone nitroglycerin. That doesn't work. Patients with normal microcirculation don't need nitroglycerin. There's no need for it. And although the effect was not significant, there was a lower survival in the patients treated with nitroglycerin. And that, whether it was caused by nitroglycerin or not, there's no causal relationship. But, I mean, clinically it doesn't make sense to give someone nitroglycerin who has a normal microcirculation. So I think you should keep it to the abnormality. And there is something new. This is a paper in Press by Mathieu Legrand from Paris. And he had these patients with these severely compromised peripheral perfusion, blue and cold, after a longer time of treatment. And so the duration was already hours. I don't remember exactly. Time from admission, 44 hours. So they were more than 24 hours in this bad circulatory state. And then finally he said, let's do something crazy. Let's give iloprost. And what he showed is that the iloprost increased cardiac output. And he has some very nice pictures where you can see the baseline here, very abnormal microcirculation, and very nicely corrected with this vasodilator in abnormal patients. So in conclusion, impaired microcirculation is an important aspect of circulatory dysfunction. Changes in microcirculation perfusion do not always parallel changes in macrocirculation. The incoherence that Chan Inche talked about. The mechanism by which vasoactive agents improve your microcirculation are not limited to the effect on blood pressure or cardiac output. A standard addition of a vasodilator to every patient, I don't think it adds much it doesn't make much sense, and it doesn't add much. And vasoactive agents like dobutamine, norepinephrine, nitroglycerin, levosimendan, and even iloprost may all improve microcirculatory perfusion in specific patients. And I think that identifying and understanding the key circulatory problem at hand in your patient may help to choose the best vasoactive agent. Thank you very much.